Olá, eu sou Lúcia Helena, falando diretamente do 26º Congresso da SBOC. Estou aqui com o Dr. William, que liderou a Comissão Científica deste evento, e com um dos principais convidados que nós recebemos aqui, o professor Richard Sullivan, do King's College London. Thank you, Professor. Which is the challenge in balancing innovation, sustainability, and a more patient-centered healthcare system?
We've had, I think, remarkable successes in the fight against cancer. Over the last 20 years, we've had an extraordinary explosion of innovations in surgery, in radiotherapy, in new cancer drugs. And this has been fabulous for patients because it's dramatically improved survival in lots of cancers. But there's a serious issue now, which is the financing and the financial sustainability around these new innovations. And it's important to realise that with any sort of progress, the progress has to be paid for.
Yes.
And needs to be paid for through taxation and social protection mechanisms, because without that, what happens is patients end up paying out of pocket. And that often leads to many patients to financial catastrophe, and it ruins the families. So whilst we've had fantastic innovations and real progress here, it's putting enormous strain on healthcare systems, doctors, hospitals, to continue to finance this in a sustainable manner and to achieve what we consider to be progressive universalism, universal health coverage. So this is I think it's the challenge we have now in cancer, which is financial sustainability of our innovations.
And Richard, we often think about innovation as, new drugs or new machines or what have you, but there are also perhaps innovative ways to finance the healthcare system. So what do you see some of these, new financing models that could be applicable to universal healthcare systems?
Yeah, there's a range now. As most countries now are struggling with this problem of financing innovations in cancer care. And so what people have been doing is looking at how to pay for innovation. Some of the most extreme examples, for example, are almost like taking out mortgages in order to pay for some of the really expensive innovations, for instance, CAR T therapies, which can, reach, nearly $1 million for treating individual patients. But within that as well, there are various pay-for-performance models with individual innovations, and governments now, and I think generally, are looking at a blended financing model. And this is something, though, that I think most people find very, very difficult to get their heads around, because governments, by and large, want to use very simple payment mechanisms. What we need now is much more sophisticated ways for financing and paying for our innovations.
And that obviously gets to the topic of health technology assessment, right? So what do you think should be, the next steps so that we can balance the innovations with what people really need and what they can access?
It's interesting because health technology assessment is still a relatively evolving, immature area. There are countries like England, like United Kingdom, which has a relatively mature health technology assessment program now. But for most countries, they're still feeling their way. And there isn't one size fits all with health technology assessment. There's lots of different adaptive methods that can be used, but they are really important to put in place because they help a country and they help citizens of that country and doctors make decisions about what they're willing to pay. And these health technology assessment programs for cancer drugs, for radiotherapy, for new diagnostics need to be put in place, because without those, it's very, very hard to prioritize the innovations which have got real clinically meaningful benefit, that are going to really improve outcomes above those which are marginal, maybe nice to have, but aren't essential. So I think over the next 10 years, most countries will have some form of HTA. And I think that's particularly important for cancer, where we're seeing so many new drugs and new multi-cancer early detection tests coming through the system.
You are also coordinator of a cancer program in World Bank, and I don't know if I understood in the right way, but yesterday I listened to you telling us that you have a new strategy for next year, and Could you give us a spoiler about this?
Yes, that's what we
Because I know journalists, we love spoilers.
So we're very lucky at the Institute of Cancer Policy, which I direct at King's College London, to be asked by the World Bank to work with them on a cancer strategy for their individual country teams and for the bank overall. So the World Bank Group obviously is a major lender, and when you look at many countries around the world, they rely very heavily on what we call multilateral development banks, and that includes the African Development Bank, the Asian Development Bank, etc. And it's quite remarkable because, generally speaking, these sorts of banks do not treat healthcare as specific domains. In other words, infectious diseases, cancer. No, it's very generic. They fund public health, they fund primary healthcare, they fund general health system strengthening. But they recognise that there is a serious problem with cancer, which is the cost for countries to deliver national cancer control plans, and also the sheer complexity to implement those plans in reality. Cancer is, it's been called the emperor of all maladies. It is from a biological perspective, and it is from a systems perspective as well. So it reflects all the strengths and weaknesses of healthcare systems. So we've been essentially working on understanding the cancer transitions that countries are going through. That includes all of the low and middle income countries, because this is really what this is directed at, not at high income. To understand how the bank is going to lend money to those countries for the individual aspects of their cancer planning. There is an issue at the moment that the narrative is every country must have a fully comprehensive national cancer plan, which is a nice thing to do if you have a lot of money. But the reality in most countries is they don't have the fiscal headroom. So actually what they need to be able to do is focus on those cancers and those elements of the system which are going to give them the greatest return. And for example, colon, breast, cancer cervix, and then you think about the individual modalities, surgery, radiotherapy, chemotherapy. So building the basic building blocks. So without spoiling things, because it won't come out until next year, it's very comprehensive. It's looking at how the bank will lend, and also looking at the future in terms of digital transformation, the use of artificial intelligence. So it's a very, very wide-ranging practical strategy, which will complement the domestic resource mobilization that countries will also have to engage in.
And that's not restricted to low-income countries, but should be applicable to middle-income countries like Brazil.
Exactly. And without going to the complexities of financing, low-income countries, of course, are in a much more difficult position. For most of those countries, cancer is not the primary problem, even though they may want to fund parts of their cancer control system. Whereas a country like Brazil is almost fully transitioned, so you're looking at very different funding mechanisms, concessional loans as well, to help build your national cancer control plan and actually implement that. So I think it's a really positive step in the right direction, and it's really the first time that these multilateral development banks have really seen cancer and said, this is something we need to do specifically.
And would that be restricted to patient care, or does that include research aspects of cancer control, etc.?
That's a really good question. We don't know yet. So we've made obviously a very strong argument that research needs to be as part of this and needs to be funded as part of it. It isn't traditionally part of their funding mechanism. Usually this goes directly to patient care, but it of course goes to prevention strategies as well and public health. But obviously in cancer, research active countries do much better than non-research active countries. There's absolutely unequivocal evidence that that's the case. So I think the bank is trying to evolve its thinking about how it might help lend into countries to build research capacity and capability, but we're early days yet.
And you also work for World Health Organization in non-communicable diseases, and they are all linked to each other. How can you see this a strategy that can just combine all these diseases together?
It is actually really rather complicated because, from a technical perspective, the World Health Organization obviously is the lead agency, But we have to remember the International Atomic Energy Agency is also extremely important and powerful within the UN system, because within its remit is radiotherapy, nuclear imaging, radiology, and that is, of course, a core area for delivering cancer care. And then we have, from a registry perspective, for epidemiological evidence, the International Agency for Research into Cancer in Lyon as well. So those three agencies between them oversee, from a supranational level, cancer from a technical perspective. The focus at the moment in the World Health Organization is childhood cancers, which is co-led with St. Jude's in Memphis, elimination of cancer of the cervix, obviously, and breast cancer. All very sensible areas. But I think there's a feeling now that we need to expand a little bit.
Yes, I mean, because of prevention, for example, obesity, you have a link between diabetes and breast cancers, for example, and with more tumors or...
Yeah. I think the prevention agenda is a complicated one, because we tend to think about that just within cancer. But as we all know, prevention and public health are good for all diseases.
Yes.
And the strategies often that we need at country level cut across areas that cancer is not really involved in. So education, ministers of transport,
literacy,
business,
pollution.
Yes, of course.
But we're not winning the battle against prevention.
Yeah.
I think there's that big problem on the prevention agenda.
Yes, I think so.
And
I
Richard,
agree.
going back to the HTA, Health Technology Assessment, I think the UK perhaps has been one of the most mature systems in that area. What do you think were some of the missteps that were taken there, and that perhaps we could learn from as we evolve our own system here in Brazil?
Yeah, I think the first thing is to have a very honest dialogue with your citizens about what HTA really means. And the reasons that we have HTA. We didn't really communicate this properly to the citizens in the United Kingdom, who thought this was rationing. It was rationing, and we were not getting access to effective technologies and effective innovation. And so I think the first thing we made a mistake on was the narrative, engaging the public so they understand why we're doing this, that this is for the good of everyone. The second is we focused too much on cancer drugs. We needed to look at other technologies. So we discovered other technologies.
For example?
Well, in the early days, surgical robots moved in very quickly into the UK without any form of control. It caused a collapse in many hospitals who lost patient loads to other hospitals. We saw massive inequalities grow over the first 5 years of the robots getting in. So this is a kind of warning. And the third thing, I think, is the legal aspects. Is we had a lot of legal challenges. There was a lot of political short-circuiting of NICE, creating the Cancer Drugs Fund, which wasted about £1.3 billion because it was ineffective, totally ineffective. And so you've got to get the legislation and the politics correct. Otherwise, you will constantly be in a war in the courts, or you'll be constantly in a battle with whatever political elite is in charge. Over there, I think, the three main learnings.
And we hear a lot of criticism that perhaps a very strict HTA has led to worse outcomes in the UK compared to the rest of Europe. How do you see that?
Yeah, there's zero evidence for that. In fact, when you look at the UK, our access to clinically effective systemic therapies is as good as anywhere else. And indeed, even those which have not gone through the HTA process are often available on a compassionate basis. The problem with our outcomes in the UK are twofold. The first is we have delays in diagnosis, and then we have delays in certain types of treatment. And this is entirely due to the fact that social determinants have become worse in the UK over the last 15 years.
Why?
Number one is our economy tanked. It's just been flatlining, and a lot of this was due to Brexit. It was due also to government policies at the time, and secondly, money was simply not put into welfare system and was not put into the general health system. So we've been flatlining in our healthcare investment for about 14 years. In real terms, that means it's been going down, and it's like a super tanker. If you go the wrong way for this long a time, it will take another decade to get us back again.
Yes, of course.
And the other problem we have National Cancer Audit, is quality. We have serious quality variation, 5-fold difference in mortality from individual cancers depending on where you live, and that's entirely due to the quality of the care. So we have the most detailed intelligence on time and cancer care of any country on the planet. So there's no excuse for not improving things. It's not as if we don't know, and we do know where the problems are. So it's a warning. I think looking at the United Kingdom and England particularly is useful because it will give you an early warning to other countries of where the problems are.
Yes.
And let me get your thoughts a little bit on as we become stricter on evaluating the HTA, which I think is a way to go. I mean, you don't want to have drugs out there that only have marginal improvements in outcomes. Do you think that there could be a downside of curbing innovation? People will not invest in finding new drugs because the bar is going to be so high to get an approval, and that goes for drugs, but I think it also applicable to
new
other
technologies.
technologies.
Yeah, I do think we're in for a bit of a battle over the next decade because on the one hand, the bar for getting marketing authorization for drugs is getting lower and lower and lower. From the FDA, from the EMA, Project Orbis is just driving down the evidential requirements. And it's easier and easier to get new non-medical technologies as well into markets. At the same time, they're all coming with a high price tag. People are going well beyond what the market will bear for the price of that technology. And every time you put a new technology into the system, you have a cost to deliver that.
Of course.
And those costs are also going exponentially. Once upon a time with chemotherapy, we might have treated people for 3 or 4 weeks. Now we're talking years on treatment. So the cost impact is enormous.
Yeah.
So I do think the argument for the moment from industry is we need the returns in order to generate the next level of future investment. Yeah. But the work we've done and others have shown returns on investment in pharma at the moment are between 500 and 3,500%. Okay. So there is a limit, and again, this is a societal decision. What is fair profit? And I don't blame industry. It's really interesting. I've changed my views on this because industry is there to make money. And if any CEO said, I want to reduce the profit, would be immediately fired.
Yeah, of course.
It's society. It's our rules of society that dictate really where we put the boundaries.
Well, especially with a publicly funded company,
yes,
they have to. That's their mandate,
exactly
right? They have to be profitable.
Right. They have to work within limits. But I think I personally look towards more public innovation. I think public sector can be very innovative if they're financed by governments. So I think governments ought to be funding more public innovation, public good innovation. I think the entry of China into cancer innovation is going to radically change things because we will see new forms of funding, global funding, new forms of technology, which probably will not command the prices that Western technologies command. And I think that will be really disruptive in a positive way.
And I'm glad you mentioned public innovation because the way that I'm seeing how oncology is going, particularly for systemic therapies, this is now dominated by private funding, right? So are you worried about that? Because I certainly am.
Yes, and I come from an era when I started a long time ago now. Cancer research came when I was the clinical director. We had a publicly funded new drug discovery pipeline. People forget that they used to exist publicly funded. I mean, temozolomide was a shearing plough drug that was funded by CRC, by us. So it can be done. There's this idea that it has to be purely private. So the issue I think is for governments is to realise they can't just say, it's all being funded by the private sector. We don't have to put money into research. I think every single government in middle and high income countries should be funding cancer research and should be funding, and I include here, public sector, public good, cancer drug development. Why not? And doing the sort of research as well that's going to help us, in my view, use less to deliver more. So for instance, lower dose immuno-oncology, moving IO up to the neoadjuvant
Use
position.
less to deliver more.
Yeah, just use, because we're using too much at the moment. Our patient treatments are too long. We're using, in my view, too many drugs. We're using too much of it, so the doses are too high. We're doing too many cycles. We're keeping people on treatment for too long. And that's because we don't know when to stop. Now, it's not going to be in the interest of industry to do those sorts of trials, but it should be public sector trials.
Absolutely, yeah.
And this is what government should be funding.
What about alternative sources of funding, such as philanthropy, etc.? Do you think that could be
hugely important? We're very lucky in the UK. We have
Yes.
a Cancer Research UK. A lot of European countries do.
Non-governmental.
Yeah.
Yes.
And it would be, I
Organizations.
mean, you would say something like a country like Brazil ought to have a very large public funder, philanthropic funder, to gather funds and disperse them. And that works really well as well, because that balances out the private sector interests.
Could you establish a parallel between this situation in the United Kingdom and Brazil? In your vision?
Well, I think that there are many similarities, and it's one of the reasons why I invited Richard to come to the conference.
Yes,
because
I am surprised.
I
didn't imagine.
We have, I think, the largest universal healthcare system in the world, and the UK has perhaps the more advanced universal healthcare system in the world. It's not as big, but it's certainly more advanced or more mature, I would say. So I think, that in and of itself is a huge similarity, and we need to learn from the experience
Yes,
of the
it was
UK.
a benchmark and all.
Yeah, absolutely. But on the other hand, I think we have less resources than it's available in the UK. So I think we have to be even wiser on how we're going to use our resources, right?
It's
It's interesting. I think you're absolutely right. The NHS and SUS have remarkable parallels, and you're of course a demographic leviathan, as we like to call the Brazils. This is the size of the country, the number. So your challenge, I mean, as an island nation, we're kind of, in a sense, relatively straightforward in comparison to Brazil. But you're right. I think the fiscal headroom problem is for both countries in different ways.
All right. Okay. Well, thank you very much, Richard. I think it was great having you here at the
Huge pleasure.
conference.
Thank you so much. Amazing conference, by the way. One of the best in the world I've ever been to.
yes,
So,
yes, I
absolutely. I
think
was saying
so.
yesterday, superb.
Yeah, you can congrats.
I know. Really, I mean, credit where
this is the
credit
man.
is due.
This is the responsible for
Absolutely
this
fantastic.
No,
fantastic
Yeah.
conference.
This
really,
was-
really super.
This was a team effort, and I hope that the oncologists have started thinking a little bit harder about all of these complicated intricacies between innovation, funding, sustainability, access. I think that's the kind of dialogue that we need right now. Thank you very much for coming.
Thank you
Great
so
pleasure.
much.
Thank you so much.
E eu gostaria de convidar todos vocês para acompanhar as nossas entrevistas no canal da SBOC.